So, a very good evening to all the participants who have joined for the Spice Route India and AFPI classroom session for the month of November. Actually, this is the first session that we are conducting after the new council have been selected, and we have chosen a very important topic that is management of UTI in clinical practice, which is a very commonly encountered condition that we come across in our clinical practice, which is very relevant from family medicine's perspectives in all stages of care, primary care, secondary care, or tertiary care. And to speak on this topic, we have one of the eminent faculties in the field of infectious disease, Dr. Mohammed Nias. Sir is a graduate of Dr. SMCSI Medical College, Karakoram, and he did his post-graduation in internal medicine from Government Medical College, Calicut, and completed his DM in infectious disease from All India Institute of Medical Science, New Delhi. And currently he is consultant in infectious disease at Department of Infectious Disease in Kim's Health, Trivandrum. And I couldn't find a better speaker than him for delivering this topic. Over to you, sir.
Thank you, Vishnu, for this kind of introduction. I'll just share my screen. I hope it's visible.
Yes, sir, it is visible.
So thank you, Vishnu, for inviting me and for the kind of introduction. So basically, straight away go to the topic, urinary tract infection. So an update. Basically, you'll be dealing with quite a few clinical scenarios related to infectious disease that we commonly come across. So just start with the clinical case. The 56-year-old lady with diabetes presents with complaints of dysuria, increased frequency, and suprapubic pain. And on laboratory investigation, there is increased pus cells in the urine microscopy. So before we go to analyze this case and what to do about it, now there is one thing that is striking. So increased pus cells. So what is called as pyuria. So what exactly is increased pus cells? When do you call a patient has pyuria? So there are three methods by which you can measure the number of pus cells in urine. They can use hemocytometry, flow cytometry, or counting pus cells in the sediments of centrifuge urine. Previously used, like the laboratories used to count the sediments in centrifuge urine, but currently it's mostly either by hemocytometer or a flow cytometer. And pyuria, by definition, is at least 10 leukocytes per millimeter cube of midstream urine, or 5 to 10 leukocytes per high power field if you're doing all the methods of counting the number of pus cells per high power field. But this is pyuria, but can we use this particular cutoff of pyuria to say that a patient has urinary tract infection? So this is an interesting study which was recently published in the Clinical Infectious Diseases. So where they looked at the current pyuria cutoff of 10, whether it lead to inappropriate urinary tract infection diagnosis. Now, this is something that we commonly do. If you see like 10 pus cells, 20 pus cells, 100 pus cells in a patient presenting with non-specific symptoms also, we always have a tendency to brand it as UTI and treat it as UTI. Many of the times it may not be actually so. So what they did was they analyzed the sensitivity as well as specificity of various cutoffs for pyuria. So first they looked at the cutoff of 10 cells per microliter and looked at what is the specificity and sensitivity. Now sensitivity definitely will be 100, all the cases it will detect. But look up this cutoff for urinary tract infection, it is only 36% of the time. So which means that like maybe like around 65% of the times, if you're using a 10 as a cutoff, you'll be diagnosing things that are actually not UTI as UTI and treat them with antibiotics. So this cutoff of 10 actually may not be actually correct. It's the first point that I have to make. Even if you're taking a cutoff of, may say 200 cells, at that point of time, the sensitivity becomes less, obviously. So since the number is required to make a diagnosis is high, the sensitivity comes down, but the specificity becomes better. So there is an argument that we should be using a higher cutoff to call as pyuria for the diagnosis of urinary tract infection. Anyway, pyuria, what I wanted to say is non-specific. Patients with pyuria may or may not have infection. The absence of pyuria should strongly call into question a diagnosis of UTI. It means that though it is non-specific, In a patient, you are suspecting urinary tract infection, it's very unlikely that they will not have any pyuria. So both ways important. Now, all pyuria, as I told, need not be infections. Okay. Now, pyuria can have a urine culture positivity. Here again, it can be a symptomatic urinary tract infection, or it can be asymptomatic bacteriuria also, in which there is only a colonization, the patient is actually not infected. Then there is what is called a sterile pyuria, where the patient has pyuria, but the urine culture is negative. This can occur due to infections. For example, tuberculosis, genitourinary tuberculosis is one common cause. Then there are other organisms called as the genital mycoplasmosis, which can also present in a similar way as sterile pyuria. But sterile pyuria many of the times can be non-infectious also. Okay? Non-infectious causes like interstitial nephritis, such things can also cause pyuria. So this is broadly about pyuria. So we go back to the first case, the 56-year-old lady with diabetes, presents with dysuria, increased frequency in suprapubic pain, and increased pus cells in urine microscopy. In infectious diseases or for clinical medicine as such, the first step is to make a clinical diagnosis. So this is a 56-year-old lady, and she's presenting with dysuria, increased frequency, suprapubic pain. So what is the clinical diagnosis that we should make? Also, this is a urinary tract infection that you should be able to differentiate between two things, that is cystitis and pyelonephritis. So cystitis, by definition, is the infection of the bladder. Cyst refers to the bladder. It's also called as a lower urinary tract infection. So their symptoms include dysuria, increased urinary frequency, urinary urgency, suprapubic pain, or hematuria. On the other hand, pyelonephritis refers to infection of the kidney or the ureter. It is also called as the upper urinary tract infection. Here are the signs and symptoms. There is signs and symptoms of systemic involvement in the fever, chills, rigor, significant fatigue or malaise, flank pain. On examination, you may get a renal angle or the costovertebral angle tenderness, and pelvic or perineal pain in men, which actually suggests prostatitis. So the crux is that if a patient is having fever of 100 degree or more, in a patient who has urinary symptoms, you cannot call it as a simple cystitis. By fever alone, you need not have an ultrasound which says that there is involvement of the upper urinary tract to call it as pyelonephritis. Fever in a patient with suspected urinary tract infection, you can call it as pyelonephritis and should be treated as such. There is a difference in the treatment of cystitis and pyelonephritis. That is why we are focusing on this. So that is the difference between lower urinary tract, that is cystitis, versus pyelonephritis. So our patient, 56-year-old lady, who is presenting with symptoms of dysuria, increased frequency, and suprapubic pain. It is not mentioned that whether the patient has fever or not. We assume that the patient does not have fever. So that is a clinical diagnosis of acute cystitis. Okay, this patient has acute cystitis. Further investigation, you can do various kind of tests. The urine dipstick tests were previously used commonly. So there are two urine dipstick tests, that is a leukocyte esterase, where detect the esterase from the leukocyte enzymes. And you also have the urine nitrase test. Basically, it depends upon the theory that enterobacteria like E. coli, Klebsiella can convert nitrite to nitrites, which can be detected via dipsticks. Now, the sensitivity and specificity of these tests actually comes around 75% of sensitivity and specificity of 82%, which means that they're not very, very good tests. They can miss cases, or sometimes they can also wrongly diagnose as well. Now, urine culture, whether you should do in all cases of cystitis is another question. The Western guidelines most often says you need not do a urine culture because the organisms are known and the susceptibility is known. But in Indian settings where we have a lot of resistant organisms, I feel that it is better that you do a urine culture and also in our cases of cystitis, so that you know exactly what you're treating in case your empirical therapy fails. So what is the empirical treatment of a patient with acute cystitis? This will depend upon your hospital antibiogram or your state antibiogram or whichever geographical area you are in. So basically, you know that E. coli is the most common cause of acute cystitis. So then we will have to look at oral option. You're not going to admit a patient with acute cystitis and give them intravenous antibiotics. That is not something that you want. But then you look at the antibiotics which can be given orally. So ciprofloxacin is an antibiotic that you commonly give. But look at the susceptibility. This is my hospital antibiogram. Your hospital has your own antibiogram and wherever you're working. and the state. This is almost similar in, at least in Kerala. Like, so ciprofloxacin, like, this is a sensitivity. So only 32% is sensitive. So you're empirically treating a patient of UTI with ciprofloxacin, which means that 70% of the time you will be failing. Or you use an oral cephalosporin, let's say cefuroxime. Okay, sensitivity is only 42%. So more than 50% of the time you're going to fail. Ceftriaxone is resistant, which means that cefixime also may be resistant. Cefodoxime also resistant. In 50% of the cases, third generation cephalosporins also fail. Cotrimoxazole is an excellent antibiotic for the treatment of cystitis. Can give it for 3 days. The problem is that only 50% is still susceptible. So what is the option over here as an oral option? This is nitrofurantoin. 91% of the isolates, in some series more than that, are susceptible to nitrofurantoin, E. coli, most of the community acquired, even Klebsiella, Enterococcus fecalis, they're all susceptible to nitrofurantoin. So in our setting, the treatment of choice for the treatment of acute cystitis will be nitrofurantoin 100 milligrams PD for 5 days. Trimethoprim sulfamethoxazole, I told you, not very effective, 50% may be resistant. But if you have a proven susceptibility, this is an excellent oral agent for the treatment of cystitis. One double strength tablet given BD for 3 days, that is enough. Fosfomycin oral also, especially for UTI due to E. coli, you can give fosfomycin. It works well. It has been found to be almost equivalent to nitrofurantoin. The problem is that fosfomycin is an kind of a reserve antibiotic. Because IV fosfomycin, we often use it for the treatment of serious gram-negative infections. So if you're using rampantly fosfomycin, like, there is a fear that we may get many organisms that are resistant to fosfomycin. Because we have nitrofurantoin, this will be the drug of choice for cystitis in our setting. The rest of the drugs only if you don't have nitrofurantoin, if you cannot use nitrofurantoin for any reasons. Alternatives: amoxicillin clavulanate, cefodoxime, cefuroxime, ceflexin, ciprofloxacin. Only if you have a proven culture report which says that these agents can be given. Again, cephalosporins are not very good agents for the treatment of urinary tract infection, especially cystitis, and oral cephalosporins, especially if you have oral beta-lactams altogether, even amoxicillin clavulanate, cefodoxime, cefuroxime, ceflexin, not very good agents, but can be used if the other alternatives are not available. Again, follow-up culture. So like, you have treated a patient with nitrofurantoin for 5 days. Should you do a follow-up culture? Should you, like, it is a common practice to order a urine routine examination and see, see some pus cells, and to say that the patient actually is not completely treated. There is no need for that. Pus cells can remain. It is only the clinical assessment that is required. You need not repeat a urine routine. You need not repeat follow-up cultures as well. There is no point in doing a culture repeat, especially if the patient is asymptomatic. So that should not be done. So again, a pregnancy is a common condition in which patients can present with cystitis as well as other urinary tract infections. So treatment of cystitis in pregnancy, again, you should be knowing it is almost similar. Nitrofurantoin can be used, again, 100 milligrams PD for 5 to 7 days. The only thing is that you may avoid nitrofurantoin in the first trimester due to some teratogenic effect, not a very high kind of risk, but if you have alternative agents, it is better avoided in the first trimester and also at term. So third term means that it's more than 38 weeks the patient is, or a delivery is expected, because nitrofurantoin is known to cause hemolytic anemia in the newborn. So at term and in the first trimester, better avoid. Trimethoprim sulfamethoxazole also is a very good agent, but again, in first trimester, it's a folic acid antagonist. Theoretically, it can cause neurocrine defects, so better avoided in the first trimester. In the late trimester, that's at term, that is 38 weeks or more, there is a risk of kernicterus, neonatal jaundice that can develop in patients in trimethoprim sulfamethoxazole used. It is better that these drugs also is avoided at terms. But in between, both these drugs are safe and you can use it. Fosfomycin oral can be used in pregnancy. All the oral cephalosporins and the beta-lactams are also what we call a safe in pregnancy, except amoxicillin clavulanate, in which there is a risk of necrotizing enterocolitis at term again. Okay, so at term, amoxicillin clavulanate is also better avoided. So clinical scenario 2, a 56-year-old lady, okay, same scenario, but here the patient has no symptoms. Executive health checkup, there is increased cells in the urine microscopy. So a urine culture is done, okay, across E. coli in 10 raised to 5 CFU per ml. And it is sensitive to ceftriaxone, berazone, referendone. What will you do? So what is the clinical scenario? Again, what is the clinical diagnosis? This is a 56-year-old lady. She does not have any clinical features suggestive of urinary tract infection, but she has a urine culture where the organism has grown at a level more than 10 raised to 5. So this is what is called as asymptomatic bacteriuria. By definition, this is isolation of bacteria in an appropriately collected urine specimen from an individual without symptoms of urinary tract infection. And this has to be collected in a particular threshold. To say that asymptomatic bacteria is there, the organism should be found in a level more than 10 raised to 5 colony forming units per ml. Ideally, for a patient, to say that for a patient to have asymptomatic bacteriuria for treatment purposes, you should have at least 2 specimens in females, because often in females there is the possibility of contamination of the urine sample and give a false report. So always ask for a second sample, preferably within 2 weeks of the first sample. In males, a single specimen is required to make the diagnosis of asymptomatic bacteria. So isolation of bacteria more than a threshold of 10 raised to 5 CFU per ml in the urine in whom there is no symptoms of UTI is called as asymptomatic bacteriuria. Now, questions. Is routine testing recommended? Should we test everybody for asymptomatic, like in an executive checkup, somebody who has came for a normal health kind of like otherwise healthy? No, the answer is no. Second question. Can it progress to UTI? Your patient may ask you. Now, the answer here is yes. Asymptomatic bacteria can progress to urinary tract infection. It is possible. But the next question, does treatment of asymptomatic bacteria reduce the risk of symptomatic UTI in the future? The answer here is no. You treat it or don't treat it. The risk of developing cystitis or pyelonephritis in the future is same. And that is the reason we say that asymptomatic bacteriuria should not be treated in most of the individual. It is not because that it won't progress to UTI. So you cannot tell that. You cannot tell that a patient coming from asymptomatic bacteria and tell that I will not treat it because this will not progress to UTI. You have to tell that even if I give you antibiotics or not, your risk of developing a symptomatic urinary tract infection is the same. That is why I'm not giving you antibiotics. Otherwise, they'll come and create problems with you. Now, so what if your patient has pyuria? There is a culture positivity, but still pyuria is there. Can I treat it? No. Answer is still you need not have, there is no requirement for antibiotics in the patient for asymptomatic bacteriuria. But my patient is diabetic is a question, like there is immunosuppression. Now, this particular question was addressed in a randomized controls trial where they have looked at whether asymptomatic bacteria in diabetic women need to be treated or not. And what they found is that treatment of asymptomatic bacteriuria in women with diabetes does not appear to reduce the complication. By complication, that is development of symptomatic UTI. So diabetic itself should not be an indication for screening or treatment of asymptomatic bacteriuria. So where do we treat them? So these are the indications for treatment of asymptomatic bacteriuria. So these individuals, if you get urine culture positivity, more than a cutoff of 10 raised to 5, even if they do not have symptoms, you can treat. That is pregnant females. Patients undergoing urological surgery where there is chance of mucosal bleeding, neutropenic patients, and renal transplant patients. These are the 4 group of patients where treatment of asymptomatic bacteriuria is recommended. Now, particularly in pregnancy, treatment of asymptomatic bacteriuria should be done. This is because pregnancy, asymptomatic bacteriuria can lead to pyelonephritis, obviously, and also can increase the risk of preterm birth and low birth weight infants. That is the reason by which pregnancy screening of asymptomatic bacteria is recommended, which should be done in the first antenatal checkup preferably. And if the patient has asymptomatic bacteriuria, we should be treating them also. Now, this is a Cochrane meta-analysis where they found that, with various studies, found that antibiotic treatment is effective in reducing the risk of pyelonephritis in pregnancy. Also, the reduction in low birth weight and preterm birth with antibiotic treatment is consistent with theories about the role of infection in adverse pregnancy outcomes, which means that there are two main reasons. One is to reduce the pyelonephritis. Second is to reduce the low birth weight as well as preterm birth. Antibiotics can be used in pregnancy for asymptomatic bacteriuria, and the regimen of choice here is the same as that we use for acute cystitis. So you can use nitrofurantoid, you can use trimethoprim sulfadoxazole depending upon the trimester of pregnancy, fosfomycin. You can use the oral cephalosporins if the above agents cannot be used because sometimes they may be in the first trimester or at term. At that time, you can use the cephalosporins also. So this is an indication, a definite indication, especially as family physician, you will be coming across this particular situation. Pregnancy, either cystitis or asymptomatic bacteria is a common scenario that as family physicians, you are going to face. Scenario 3, a 56-year-old with diabetes, again the same symptoms presenting with complaints of fever, chills, and dysuria. There is increased pus cells in the urine microscopy. So this is again a patient who was presented with urinary symptoms, but here there is fever. We have discussed this already. In a patient with fever, you see urinary symptoms with fever more than 100, you suspect pyelonephritis or clinically diagnosed pyelonephritis. There is no need for an ultrasound to say that it is pyelonephritis. Look for, also ask for flank pain, also look for posterovertebral tenderness in these patients. So this is a case of pyelonephritis. And also you have to consider this definition of complicated UTI. Previously, the complicated definition was also complicated. Now it's made simple. Complicated UTI is any infection that goes beyond the bladder. So this includes patients who have pyelonephritis, CORTI, or any febrile or bacteremic urinary tract infection. Okay, so the older definition of all urinary tract infection in men are complicated. Those things have gone. Currently, complicated by definition, complicated urinary tract infection includes any infection that goes beyond bladder, men, male, female, doesn't matter. So that includes pyelonephritis, CORTI, and febrile or bacteremic UTI, and everything else is a uncomplicated UTI in women or men. So we have a case of pyelonephritis here. So this patient has features of fever, chills, and dysuria with pyuria. Diagnosing pyelonephritis. What will you do next? Again, you can do a blood count, your CRP, urine routine. Obviously, your urine culture is also recommended. If you have high-grade fever and admitting the patient, blood culture is not mandatory, I would say, but blood culture is ideal. Again, not all patients require an ultrasound or a CT scan. Only if the patient has severe disease with hypertension, when you suspect some collections, here you can do a ultrasound or a CT. Persistent symptoms despite antibiotics for 48 to 72 hours. Again, you can do a CT imaging. Suspicion of obstruction, which requires relief of the obstruction for the treatment to be successful. Anyway, anywhere you have an obstruction, that obstruction you have to be relieved. If you have a stone, if you have some kind of obstruction, you will have to call your urology friend to relieve that obstruction, and only your treatment will be successful. And then you have recurrent symptoms within a few weeks of treatment. Again, for some complication, you can do an imaging. Preferable imaging is a CT scan, contrast plus non-contrast, ultrasound can miss things. But again, need to be done in only patients who have these indications for an imaging. So again, when you have a patient with complicated UTI, which means pyelonephritis, you have to look whether the patient has features of sepsis or no sepsis. You can use your criteria, the sepsis 3 criteria or the SIRS criteria to say whether the patient has sepsis or non-sepsis. Also, you have to assess the patient for risk factor for resistant organisms, which will depend upon where the patient is coming from, whether the patient has received antibiotics in the past, all those things which will increase the risk of a resistant organism. And patient-specific factors, whether the patient has some immunosuppressive conditions, whether the patient is neutropenic, etc. And then your hospital antibiogram is very, very important to choose the particular antibiotic. So what antibiotic will we choose in a patient with acute pyelonephritis? So as I've told you, this is again the same antibiogram. This is the community-acquired urinary infection in our hospital. So the most common is E. coli. So you look at what is the common antibiotics that you can give. Always look at the narrowest spectrum. If you look at cephalosporin sulbactam, okay, cephalosporin sulbactam, so third generation cephalosporin with the beta-lactamase inhibitor, also pyrazinamide tazobactam, they have around 90% susceptibility. So What about ceftriaxone? Ceftriaxone is an injectable antibiotic, it's only 50%. So patient is coming with pyelonephritis and you're giving ceftriaxone 50% of the time, you may fail. And you don't want to do that. Like, I mean, whenever you're choosing an empirical regimen, it should be at least 80% times you should be successful. So that's the dictum. So you have to use either cefoperazone sulbactam or piperacillin tazobactam. The carbapenems, ertapenem is very good, 97% susceptibility, meropenem also almost similar susceptibility, but that you may reserve, especially for patients who are sick or the patients who are in sepsis. Otherwise, for most of the patients in our setting, cefoperazone sulbactam or piperacillin tazobactam are good enough antibiotics. So empiric therapy in patients who have no sepsis, piperacillin tazobactam or cefoperazone sulbactam. Patients who has sepsis, meropenem or ertapenem may be preferred over piperacillin tazobactam or cefoperazone sulbactam, especially if the patient has bacteremia. It is not a hard rule like you have to use meropenem. The IDSA guidelines say that these agents may actually be almost similar, but it is okay to use a carbapenem in patients who has sepsis, especially shock. So again, this is the same. So this, like I'm talking from the ID week. So they have published this new guidelines in ID week 2023. So in which they says that if a patient have proven susceptibility, it doesn't matter. Okay, if the patient has proven susceptibility to fluoroquinolones, third or fourth generation cephalosporins, piperacillin tazobactam, or carbapenems. So any patient who are even in the patient with or without sepsis, you can use these agents with equal efficacy. So if the patient is having a urinary tract infection, pyelonephritis, and your bacteria is susceptible to fluoroquinolones, you can switch to fluoroquinolone. If the bacteria is susceptible to ceftriaxone, you can shift to ceftriaxone. So there is no added advantage in continuing the carbapenem or a beta-lactam-beta-lactamase inhibitor combination. So that is again, so once susceptibility is proven, none of these drugs are superior over the other drugs. Now, you are starting a patient of urinary tract infection with antibiotics, intravenous antibiotics is given. Now the patient has clinically improved. Now, can you, like, it's always the patient will be asking you for a discharge, whether you can discharge the patient and what are the criteria to discharge the patient on an oral antibiotics. So the oral antibiotic, to shift to oral antibiotic, the patient should meet some criteria. The patient should be afebrile or the fever should be improving. The patient should be hemodynamically stable. The BP should be okay. And the source control, if needed, should be done. If there is any obstruction, it should be removed. If there is any abscess, it should be drained. And there's no further procedure that is needed for controlling the infection. If you have these criteria met, then you can shift to an oral agent. But your oral agent, again, should have certain criteria to be met. It should be an agent which achieves a good level in the urine, tissue, and blood. Okay, you cannot use nitrofurantoin to complete the oral therapy because it has poor levels in the urine. So nitrofurantoin in any way should not be used for pyelonephritis because it has poor blood levels, though it has excellent urine concentration. So it's a drug of choice for cystitis, but it is not to be used in pyelonephritis. So what are the agents that you can actually use? So two agents mainly. One is if the organism is susceptible to quinolone. Second is the organism is susceptible to a trimethoprim sulfamethoxazole, that is Septran. These are two agents where you can confidently shift to oral agents after your IV therapy for 2 or 3 days, and the patient is clinically improved and has become afebrile. You can shift to quinolones and ciprofloxacin or Septran. And what is the total duration of treatment? Total duration of treatment of acute pyelonephritis is 7 days. It's not 10 days, it's not 14 days, it is 7 days. Even if the patient has bacteremia, current guidelines says that you can treat this patient with 7 days therapy, and that is sufficient. Okay. Next question, a 48-year-old female uncontrolled diabetes mellitus presenting with fever of 5 days duration associated with chills and flank pain. Examination, the patient is in hypotension, blood and urine culture grew E. coli. So what is this? Again, slightly a complicated case. So this is CT scan given. Anybody want to, just to make it interactive, anybody want to make a clinical diagnosis? What do you see? Yeah, yes, very good. Somebody has answered it. So for the others, you can see there is a kidney here. So that is the right kidney, there's a kidney here, this is left kidney. So the right kidney is normal, it's no problem. But left kidney, you can see there are many air pockets. Okay, whatever black in here is air. So air in the kidney, so you call it as emphysematus. Pyelonephritis is a kind of severe pyelonephritis. Most common organisms is again E. coli. So here again, the treatment is almost the same. You treat with antibiotic, and the duration is usually 14 days. But something additionally you have to do is that you have to do a source control. The source control here will be most of the cases to do a percutaneous drainage. Okay, so you drain the emphysematous things, drain the air and the pus, then treat with antibiotics for 14 days. So that is emphysematous pyelonephritis. So again, just the same for as any other complicated UTI, you can use antibiotics, can shift to oral after improvement. Total duration is 2 weeks. So in patients who has gas, so percutaneous drainage should be done. If this is very small without any extra renal drainage, you may even defer the drainage, but most of the patient will require drainage. Clinical scenario 5, a 56-year-old lady again presents with complaints of dysuria, increased frequency, there's increased pustules in the urine microscopy, but she had similar history in the last 6 months, 2 similar history. So the patient has dysuria, there is increased frequency. So current clinical diagnosis is acute cystitis, but the problem is that she's getting recurrent symptoms. So when you call a patient has recurrent cystitis, so this is when a patient has more than 2 episodes, more than or equal to 2 episodes of UTI in 6 months, or more than or equal to 3 episodes of urinary tract infection in 1 year. So this is again a very common situation that you are going to face in your clinical practice, especially as family physicians. Many elderly females are going to come with this particular syndrome of recurrent UTI, particularly in elderly females, diabetic females. This possibility of recurrent cystitis is quite common. What do we do to prevent? Now, this acute cystitis you can treat with nitrofurantoin, as we have already mentioned. But what do we do to prevent it? So, we all used to hear this, no? I mean, your parents do, or our grandparents used to tell this, that is, you should increase your water intake so as to prevent urinary tract infection. Is this true or what? In scientific terms, has it been proven? In fact, it has been. So it has been proven that increased daily intake of water in pre-menopausal women with recurrent urinary tract infection. So what they did was an RCT. How difficult it would have been to do an RCT with making people drink 1.5 liters of water per day. But anyway, they have done it. Participants were randomized to either take one additional 1.5 liter of water per day or no additional fluids. It was found that patients who had an additional intake of water, they had fewer episodes of cystitis and fewer antimicrobial courses done. So this is particularly something that you can easily suggest people. They can take around 2.5 to 3 liters of water per day. So that can, in fact, decrease the risk of urinary tract infections. Again, often prescribed thing that is cranberry products, cranberry juice. Not commonly available in India, but the tablet form is available in this marketed along with the D-mannose. So this again is has been studied actually, cranberry. So overall clinical evidence suggests that cranberry products actually can reduce the frequency of simple cystitis in patients with the recurrent urinary tract infection. So you can give cranberry also. So what basically cranberry does is that the cranberry contains what is called as proanthocyanidins, which can bind to certain molecules on the E. coli. Okay, so that is the P. fimbriae. It will go and bind to the P. fimbriae, and it will prevent the fimbriae from binding to the uroepithelial cells. So that is the scientific explanation for cranberry products. So this Cochrane meta-analysis has found that cranberry products may actually reduce the frequency of simple cystitis. Again, simple things that you can suggest. Plenty of water, cranberry products can be suggested, but many patients will require pharmacological therapy. So in patients who are having recurrent episodes like more than or equal to 2 per 6 months or more than equal to 3 per 1 year, so you can suggest pharmacological therapy. Now pharmacological therapy can be continuous. So you give for an indefinite period, that is 100 milligrams of nitrofurantoin every day they can take. Okay. Or it can be post-coital. In some premenopausal women especially, the UTI will be triggered with the sexual intercourse. In such females, it is better that they can, and the sexual intercourses are infrequent, they can take it as a post-coital prophylaxis. That is a single tablet of nitrofurantoin after sexual intercourse can be suggested. So that is more convenient for them to take. But if it's occurring, even like this is only for patients who have a recurrent UTI, especially related to sexual intercourse. For others, you may need to give continuous prophylaxis. You can also, trimethoprim sulmethoxazole is also an additional, alternative to nitrofurantoin. You give a half single strength tablet, so that is required. Half single strength tablet given continuously. How long? Nobody knows. You may give 3 months, 6 months usually. Sometime up to like years also, people may take this to prevent urinary tract infections. So that's it. Thank you. Any questions?
So thank you, sir, for enlightening on all aspects of urinary tract infection. If you have any questions, I would kindly request you to put it up in the chat box. So there is a question that if the recurrent cystitis need to be the same organism.
By definition, it need not be like whatever number. If you get number of it is more than or equal to more than 2 per 2 months. I mean, in 6 months you can call it as recurrent cystitis.
So when do we suspect genitourinary TB in a person with recurrent UTI? Is another question in the chat.
Yeah. So basically, again, these patients can present with recurrent urinary tract infections. Okay, they may or may not have a prolonged fever. The typical symptoms that you get in tuberculosis, like prolonged fever, weight loss, may not be there. So they may present with recurrent urinary tract infection, particularly because there is many obstruction to the urinary tract infection due to the chronic infection by tuberculosis. In such patients, mostly, sometimes you may even get culture positivity due to recurrent infection. But sterile pyuria, definitely you should think. Urinary tract abnormalities, obstruction in the urinary tract, which can be made out by imaging, like thickening of the bladder, thimble bladder, ureteric stenosis, such kind of things in a patient with recurrent UTI. Again, you think of urinary tuberculosis, very difficult to diagnose. You have to send 3 samples of early morning sample, preferably of urine for culture. Urine gene expert, very unlikely to be positive, but still we send it. But most of the time, based upon the imaging, is we decide to treat a case of genitourinary tuberculosis. Delaying the treatment actually will be very harmful for the patient. They will develop permanent strictures and fibrosis, which can be very difficult for the patient.
So another question is, what is the role of alkalizing agent?
Alkalizing agent, again, the evidence is not very much to suggest alkalizing agent for the treatment of urinary tract infections. We usually do not suggest that.
Okay, thank you, sir. And another question, a very interesting question: what antibiotic to give when saviceptastenum is not effective?
Okay, so it depends upon what are you treating. There are many antibiotics. Saviceptastenum is not the last antibiotic. It will depend upon what is the organism. The polymyxins will be still susceptible. Tigecycline, fosfomycin may be still susceptible. Something newer is coming, cefepime, zidibactam. Saviceptastenum, most of our Klebsiella are susceptible to the combination. In E. coli, there can be some resistance. 30% of E. coli can be resistant to the combination. The cefepime zidibactam is something that we are expecting very soon to come to the market.
I hope that question is answered. And another question, sir, in COTI, is it 1000 CFU still the cutoff for diagnosis?
Yes, at 10 raised to 3 CFU per ml can be used the cutoff for COTI.
So another question is, what is the treatment for Candida infection in culture?
Again, I should have told that Candida infection, most of the times, if you find Candida, it is asymptomatic candiduria, does not require any treatment. Many patients who are on long catheterization will have Candida in urine. There is no need for treatment. Simply, you can remove the catheter. That alone will be sufficient. Now, there are patients who require treatment. That includes symptomatic patients, asymptomatic patients who are neutropenic, asymptomatic patients who are undergoing urological procedures can be treated. Here again, what we have to make sure is that like you can treat with fluconazole. If it's cystitis, 200 milligrams OD for 14 days. If pyelonephritis, 400 milligrams OD for 14 days. That is if the organism is azole susceptible. If it is azole resistant, it is very difficult because your echinocandins does not attain good urinary concentration. Liposomal amphotericin also attain very poor urinary concentration. Finally, you are left with conventional amphotericin B or flucytosine are the two options.
Thank you, sir. And another question is, should we start on antibiotics if there is only pus cells, no bacteria? I think you have already dealt with in the presentation about this.
Not really.
And when do we tell the significant pus cells in urine examination?
I already mentioned that.
That is also mentioned. And another question is it mandatory to see the radiological signs to start ATT in genitourinary TB, or can we start if 3 samples become positive?
Of course you can, but I don't think the other way is most common. Like, I mean, very rarely you will get AFP culture positivity. Most of the time you end up in treating with the urinary tract radiological imaging, and the other way is very rare to happen actually.
Thank you, sir. And another question: will TG work in UTI?
As like any tetracycline, or TG is a glycyl cycline like tetracycline. This has a big, what you call as volume of distribution. It distributes to the tissues entirely, but its excretion in the urine is not very good. So tigecycline is not a preferred agent for the treatment of urinary tract infections.
So the next question is, what is the minimum duration for prophylactic treatment in recurrent UTI?
Thing like that, usually give at least for 3 months.
Okay. And next question we have is antibiotic of choice and the duration in patient with CKD or any other renal disease.
Again, it depends upon your creat clearance. If the creat clearance is less than 30, nitrofurantoin should not be used. So that is there. In that case, if cephalosporin, if it available, it can be used. You can use Septran in dose modification. You can use fosfomycin also. Oral fosfomycin is safe. IV, you will need dose modification. That is first.
One more question. Is silicone catheter or medicated catheter normal catheter in a patient with pyelonephritis? Okay. I think sir got disconnected. Just a minute.
Sir is disconnected.
Yeah, I think sir got just disconnected. Just a minute.
Vishnu, can you hear me?
Yes, sir. Yes, sir. You're audible.
Yeah. Any more questions? My connection got lost.
Yeah, sir. For bedridden patients, how often should we change the catheter? As the question about silicone and polycatheter.
So basically, it is not. It depends upon catheter change is not routinely recommended other than like the patient have symptoms of urinary tract infections or candiduria or asymptomatic pyuria. Presence of some sediments alone is not an indication. Usually, if it is a duration, if more than 2 weeks, it is preferable to change to a silicone catheter.
So I think we have taken up almost all the questions. I don't see any questions in the chat. We had around 90 participants even till the end of the class. More than 100 participants were there.
We conduct a lot of meetings where we find it very difficult to get at least 50. So that's good job.
At one point, I had to block at 99 because we have only 100 participants. So I hope it was very useful session for all of you who have joined. And I would request Dr. Anuna to give the closing remarks.
Am I audible?
Yes, yes.
Good evening, everyone. Now, that was a very comprehensive yet elaborate presentation regarding the approach of urinary tract infection with respect to several real-life case scenarios. Now, UTI, as we all know, is a very common disease that we get in the general practice, even so in the PHCs, and we are expected to manage them until there is a dire need for referral. So it is very important that we are well equipped with the approach of UTI. Now, I'd like to extend my warmest gratitude to Dr. Mohammed Nias, a consultant infectious disease. Thank you so much, sir, for taking the time and the effort to compile those case scenarios, more so the most common and must-know clinical case scenarios that we face, and for the wonderful session that followed. It has covered the entire approach of diagnosing and managing UTI, just apt for the family medicine PGs and the fresh outs. The usual queries like the role of having water, how important it is that we have water to prevent UTIs, or the importance of cranberry juice, which was recently only came into picture. So all these general queries that we have as well were cleared. It was a very enlightening session, sir, especially for the young family physicians and the postgraduate students. Thank you so much. I'd also like to extend my warmest gratitude to the senior faculties who have joined the session, my dearest colleagues, as well as my juniors. With that, we conclude the session. Spice Route in the AFPI will be back with another academic session soon. Thank you. Good night.
Yeah.
Thank you all. Thank you, sir.
Thank you.